Have you ever felt just like completely swamped by information about some health issue, maybe wound care, and you just wish someone could cut through all that noise, get right to the point?
Oh yeah, that feeling of information overload, especially with complex or chronic conditions, it's really common.
Well, that's pretty much what we aim for here on the deep dive. Think of us as, I guess, your shortcut to really getting a handle on tricky subjects.
Sounds useful.
Today, we're diving into a really challenging area, the management of wounds that are, well, either non-healable or need ongoing maintenance.
Right, these are the really tough ones.
And our main source today is a big, systematic, integrative review, basically pulling together findings from a whole bunch of scientific studies.
Yeah, these reviews are great because they synthesize a lot of research. This one looks specifically at papers from, I think, 2011 to 2019.
Exactly. So our mission, if you like, is to pull out the absolute must-know insights and the practical strategies from this review. We want to help you understand how clinicians approach these really difficult wounds.
And it's important to stress we're not really talking about quick fixes or miracle cures here.
No, definitely not. It's more about understanding, realistic outcomes and what effective management looks like when complete healing just isn't the main goal anymore.
It's about that shift, isn't it, towards managing symptoms, quality of life, when healing isn't really on the table.
Precisely.
Okay.
So let's unpack this a bit. First off, we probably need to get clear on the different types of wounds we're discussing. You hear about acute wounds.
Right. Those are the ones that usually heal up relatively quickly, within a few weeks, typically.
And then you've got chronic wounds.
Yeah, chronic wounds stick around longer, generally defined as being present for more than 4 weeks and may be expected to heal within, say, 12 weeks.
But what about when things go off track? When a wound just doesn't follow that path? That's where you hear terms like non-healing or maybe hard to heal.
Exactly. Those are kind of umbrella terms for wounds that just aren't responding as expected. And a really key concept the review talks about is wound bed preparation, or WBP.
WBP, okay.
Yeah, it's a structured way for clinicians to assess the wound, look at the underlying causes, the patient's overall health, and basically figure out its potential to heal.
So using that WBP idea, we get to non-healable wounds.
Yeah.
What makes a wound fall into that specific category?
So non-healable wounds are those where the fundamental reason why the wound exists just can't be corrected. Think really severe ischemia, very poor blood flow, or maybe advanced malignancy, or other systemic conditions that just aren't treatable.
So the body's capacity to heal is just fundamentally compromised.
Pretty much, yeah. The underlying issue prevents it.
Okay, and then you mentioned maintenance wounds. How are they different from non-healable?
Maintenance wounds are a bit different. With these, the underlying causes could potentially be fixed, but healing gets stalled, maybe because of challenges in the health system.
Like lack of resources
Yeah.
or specialist access.
Right, exactly. Or it could be patient-related factors, maybe lifestyle choices, or, real difficulty adhering to complex treatment plans. So the potential for healing might technically be there, but something's blocking it.
Ah, okay. So it's a mix of things stopping the healing process, even if the root cause isn't insurmountable itself.
Mhm.
It definitely sounds like clear guidance on how to manage both types non-healable and maintenance has been, well, needed.
Oh, absolutely. There's been a gap in really specific evidence-based guidance for these situations. That's why this kind of integrative review is so valuable. It tries to pull together what we do know.
So tell us a bit about the research itself. How did they go about conducting this review? What was the method?
Well, they were quite rigorous. They searched several major electronic databases, Scopus, Web of Science, PubMed, places like that, covering publications from 2011 up to 2019.
And they looked beyond just databases.
Yeah, they also did hand searching of key journals and reference lists, trying to catch anything the electronic searches might have missed.
Sounds comprehensive. What kinds of studies actually made the cut? What did they include?
They included a mix. Things like other reviews, best practice guidelines developed by expert groups, consensus statements where experts agree on an approach, and also original non-experimental studies.
Non-experimental.
Meaning studies that observe or describe situations rather than controlled trials where you, say, compare 2 different treatments directly. And actually, that's a key point they noted, lack of randomized controlled trials, or RCTs, focused specifically on non-healable wounds.
That's interesting. Suggests it's a really tough area to study with that kind of rigorous trial design, maybe.
I think so. The complexity, the ethical considerations,
Yeah.
it makes traditional RCTs very difficult for this specific wound type. Anyway, after finding the relevant studies, they used a structured approach, a coding framework to extract the key data.
What sort of things are they coding for?
They looked at themes like how the underlying cause was treated, patient-centered concerns, what matters to the patient, local wound care strategies, alternative outcomes beyond just closure, and also prevention strategies.
Okay, so they systematically pulled out recurring themes across all these different types of studies. So what were some of the big insights, the actionable stuff?
Well, one absolutely critical theme was the need for accurate and appropriate assessment. And this isn't just a quick glance.
More involved than that.
Much more. It really emphasizes identifying those underlying conditions, the root causes, and also looking at patient factors and even health system factors right at the beginning, early on.
So digging deeper from the start.
Yes. And the review stressed how important it is to try and determine the wound's healability, its potential, ideally within the first, say, 12 weeks, using validated tools, not just guesswork.
So that early assessment is foundational.
Absolutely. And it's not a one-off thing. Regular reassessment is vital, too. They specifically highlighted checking blood supply, often using the ankle brachial pressure index, the ABPI.
That check for blood flow to the legs and feet.
Exactly. It's a key indicator. And something else quite striking was the strong link found between depression and diabetic foot ulcers. It really underscores the need to screen for and manage mental health alongside the physical wound.
That's a crucial connection. We're treating a person, not just a hole in the person.
Precisely. So the first big takeaway, thorough, early, and ongoing assessment, including mental health and blood supply.
Got it. What was another major theme?
Okay, another one was focused, evidence-based cause intervention, basically tackling the why behind the wound.
Makes sense. Get to the root cause.
Right. And the review suggested that addressing these underlying causes early can actually stop some wounds from ever becoming non-healable or maintenance wounds.
So early intervention on the cause can change the whole trajectory.
Potentially, yes. They mentioned specific things that often lead to chronicity, like osteomyelitis, that's bone infection, or certain skin cancers like squamous cell carcinoma, persistent lymphedema, or just uncontrolled infection. These all need specific, targeted treatment.
And for those wounds that are already hard to heal.
For those, the review pointed to the value of sometimes taking edge biopsies, small tissue samples from the wound edge, to really understand the pathology, what's going on at a microscopic level.
Like detective work on the wound itself.
Kind of, yeah. And crucially, they stressed the importance of making that call, classifying a wound as definitively non-healable early when it's appropriate, because that allows the whole team and the patient to shift focus.
Shift focus to what?
To palliation, symptom management, and optimizing quality of life, rather than continuing perhaps burdensome treatments aimed solely at healing that isn't going to happen. So early, realistic classification sets the right goals.
Setting those realistic expectations seems key. Which leads nicely into another theme you mentioned, quality of life.
Yes, exactly. Improvement of health-related quality of life was a huge theme. The review really drove home how profoundly chronic wounds impact people. It's not just physical.
That's everything.
Everything. Personal life, finances, social interactions, psychological well-being, even intimacy. The impact is incredibly broad.
So the takeaway is that this goes way beyond just the wound itself.
Absolutely. And because of that, consistent pain management becomes critical. That includes both systemic medications, pills, and topical treatments applied directly to the wound area.
Managing the pain is paramount.
It has to be. And alongside that, addressing depression, helping people develop coping skills, looking after their emotional needs, tackling social isolation. These are all vital components of care highlighted in the review.
Supporting the whole person.
Yes. And maintaining function, too. Helping people keep up with activities of daily living, addressing mobility issues, promoting self-reliance as much as possible. These were all seen as priorities. So the insight is really about holistic support for overall well-being.
Helping people live the best life they can, even with this ongoing wound.
That's the goal. Now, related to that is the adapted local wound care. This isn't just standard wound dressing procedures.
Right. I imagine the goals change when healing isn't the primary aim. What did the review say about that?
Well, take debridement, removing dead or unhealthy tissue. For non-healable wounds, the approach needs to be much more careful, conservative, perhaps even avoided in some cases, especially compared to aggressive surgical debridement. And surgical debridement should really only happen if there's adequate blood supply.
So gentle debridement, if any, and only if blood flow is good.
Generally, yes. Infection control, though, needs to be aggressive, both systemically, with antibiotics if needed, and locally. But interestingly, the review referenced the International Wound Infection Institute's caution against routine use of topical
Is
antibiotics.
that resistance?
Exactly. Big concerns about promoting antibiotic resistance. So, infection control, yes, very important, but needs to be smart about antibiotic use.
That's a critical point in today's world.
Right.
What about other local issues like odor? That can be really distressing.
Hugely distressing. The review mentioned several options for odor control things like topical metronidazole gel, silver-based products, charcoal dressings, medical-grade honey, even cadexomer iodine preparations.
So there are options to manage that.
Yes. And another key point for local care was keeping these non-healing or maintenance wound beds relatively dry. The aim is to protect the surrounding skin and the wound edges, not necessarily promote the kind of moist environment needed for active healing.
So different moisture balance goal.
Right. And here's something else really practical. They highlighted the edge effect.
Edge effect.
Yeah, it refers to tracking the wound size. If you don't see a significant reduction in the wound area, they mentioned benchmarks like less than 20 to 40% reduction within 2 to 4 weeks. That's actually a pretty strong predictor that the wound is unlikely to heal with current treatment.
Wow, so that's an early warning sign.
It can be. It suggests you might need to reassess and potentially change the approach or goals much earlier than waiting the full 12 weeks often associated with chronic wounds. Lack of early progress is a red flag.
That's a really useful clinical indicator. Okay, so we've talked assessment, cause, quality of life, local care. What else came through strongly?
Health dialogue priorities. This is all about communication and education.
With the patient.
Yes, making sure patients really understand their condition, prognosis, the treatment plan, and empowering them towards self-management as much as possible.
Tailoring the education.
Absolutely. Tailoring it to their learning style, making sure it's understandable, addressing modifiable risk factors they can influence, like smoking or diet. Interestingly, the review also noted a link between good health dialogue and potential cost savings.
How so?
Likely because informed, engaged patients tend to adhere better to treatment, manage self-care more effectively, and potentially have fewer complications or hospital visits.
Makes sense. Engaged patients do better.
Right. And they even touched on using technology e-learning platforms, maybe mobile apps, even social media to help with patient education, and also to involve their family or support network. So the key insight, clear, tailored communication and education are vital.
Using all the tools available. Now, you mentioned health system factors earlier. Health system challenges must play a big role too.
Oh, definitely. This came through as a major theme. Things like the skill level and experience of the healthcare professionals involved.
Competence matters.
Hugely. Especially in accurate assessment and clinical management of complex wounds. The review suggested that sometimes a lack of specific provider expertise can be an overlooked reason why a wound stalls.
So, knowing your limits and when to refer.
Exactly. Recognizing limitations and making timely referrals to specialists or specialized centers was emphasized. And of course, resource limitations funding, staffing, availability of certain dressings or technologies were acknowledged as a significant barrier to optimal care and timely healing in many settings.
The practical realities of the system.
Yes, but on the flip side, the review also argued that guideline-driven care and early identification of maintenance wounds can actually be cost-effective. It avoids potentially wasting resources on prolonged, ineffective treatments.
So being realistic early saves money later.
Potentially, yes. And not surprisingly, preventing skin breakdown in the first place was highlighted as a major priority simply due to the direct cost savings compared to treating an established wound. So system factors, provider expertise, and resource allocation are all big pieces of the puzzle.
Sounds like prevention really is key, economically too. What about those advanced therapies? You sometimes hear about things like negative pressure or oxygen therapy. How do they fit in?
Right, that falls under rational use of adjunctive modalities. Those advanced therapies, negative pressure wound therapy, NPWT, hyperbaric oxygen, HBO, various biologics, the review positions them as tools best used by specialized interprofessional teams.
Not for every wound, then.
No, primarily for selected hard-to-heal wounds after carefully considering the underlying cause, the patient factors, and importantly, the available resources and expertise. They specifically cautioned against using these often expensive modalities for established maintenance or non-healable wounds, particularly if the wound bed is dry or prone to bleeding.
So, targeted use by experts, not a first-line treatment for these non-healing types.
That's the gist. Use them selectively and wisely. Which brings us to perhaps the most emphasized finding in the entire review, the significance of interprofessional team intervention.
The team approach. This keeps coming up. Why is it deemed so critical?
The review concluded that getting a team of different specialists involved early is probably the single most important factor for ensuring correct diagnosis, appropriate interventions, and ultimately preventing wounds from becoming stuck in that chronic, non-healing state.
Because they bring different skills.
Exactly. These complex wounds often require a range of expertise: vascular surgeons, infectious disease specialists, podiatrists, dietitians, specialized nurses, physical therapists, social workers. The list goes on. These teams possess those advanced skills.
And it's cost-effective, you said.
Yes. Compellingly, the evidence reviewed suggested that this team-based approach, despite potentially seeming more resource-intensive upfront, tends to be more cost-effective in the long run compared to standard, less coordinated care, likely due to better outcomes and fewer complications.
But the catch is...
The catch, as the review noted, is that these specialized teams are often accessed too late in the process.
After the wound is already deeply entrenched.
Right. And one more crucial point here. The patient is considered a vital member of that interprofessional team. Their input, goals, and preferences are central. So, takeaway. Early team involvement is paramount.
It's about collaboration with the patient at the heart of it. So how do we make sure that team involvement happens earlier? Did the review suggest anything practical?
It did. It proposed the concept of an interprofessional referral pathway.
Okay, what does that look like?
Well, first, they clarified that hard to heal isn't really a fixed wound type, but more like a stage or a flag. It's a point where you need to determine, is this wound actually healable? Is it truly hard to heal, but potentially fixable with expert input? Does it need ongoing maintenance? Or is it non-healable?
So hard to heal prompts a deeper look at classification.
Exactly. The proposed pathway uses time markers like that lack of progress within 2-4 weeks we talked about, or failure to heal significantly by 12 weeks as triggers to systematically involve the interprofessional team.
So built-in checkpoints for referral.
Right. The whole aim is to prevent wounds from languishing unnecessarily in those maintenance or non-healable categories when expert intervention might have made a difference earlier. They even suggested an additional, say, 12-week intensive intervention period managed by the team specifically for those classified as hard to heal.
A dedicated window for the specialist to tackle it.
Yes, to give it the best shot before potentially shifting to a maintenance or palliative approach if needed. So it's about creating a structured process to ensure timely access to that crucial team expertise.
That sounds like a really logical, proactive approach. Okay, wow, we have covered a huge amount of ground here based on that review. If you had to boil it down, what's the single most important message for listeners to take away about managing non-healable and maintenance wounds?
I think the core message is that managing these incredibly challenging wounds demands a fundamental shift in perspective. It's not solely focused on achieving complete closure anymore.
It's broader than just healing.
Much broader. It requires meticulous assessment, relentlessly addressing underlying causes where possible, placing a huge emphasis on the patient's quality of life and overall well-being, and crucially, leveraging the skills of an interprofessional team, ideally from early on.
So even when you reach a point where you know a wound isn't going to fully heal, there's still a lot that can and should be done.
Absolutely. There are clear evidence-based strategies to manage symptoms effectively, prevent further complications, reduce suffering, and significantly improve that person's quality of life. It's about active, positive management, not just giving up.
That's incredibly important to hear. It really paints a picture of complex, compassionate care moving beyond just the physical wound.
It really does. And it highlights that even when we can't achieve the traditional fix, applying thoughtful, evidence-informed management makes a profound difference.
Definitely. So building on that, here's a final thought for everyone listening. Consider the implications of this kind of shift in perspective. Moving from seeking a complete fix to prioritizing skilled management, adaptation, and quality of life. How might that apply not just in healthcare, but maybe in other challenging situations you encounter problems that seem persistent or perhaps unfixable in the traditional sense? What new possibilities open up when we redefine success and focus on managing well? Something to mull over.